The title of this brief is Central versus Peripheral Jerk Nystagmus. It will be developed by answering two questions. Question number 1. Which of the following features is likely to be present in a patient with jerk nystagmus due to a pontine lesion? A. Direction, torsional horizontal. B. No change in direction with gaze. C. Inhibition with visual fixation. D. Change in direction with change in head position. E. No latency. The illustration in this frame represents the peripheral and central components of the vestibular system. The peripheral components are the vestibular apparatus and the vestibular nerve. The central component is represented by the brain. The added table lists the distinguishing features of peripheral and central jerk nystagmus. It was constructed based on a table labeled 14.2 in the 11th edition of Adams and Victor's Principle of Neurology. We will now go over the table and illustrate the features that allowed the distinction between peripheral and central jerk nystagmus. During this talk, we are only addressing jerk nystagmus. So even when the word jerk is omitted, we are still referring to this distinctive form of nystagmus. The features of peripheral nystagmus will be illustrated on the blue background. The features of the central nystagmus will be illustrated on the red background. Peripheral jerk nystagmus mixes torsional with horizontal or vertical motions and only rarely is purely horizontal. Central jerk nystagmus are pure, torsional, vertical, or horizontal. Peripheral jerk nystagmus is inhibited by visual fixation. Central jerk nystagmus is not affected by visual fixation. In this one and in the future added figurines, the thicker arrows expresses the fast component of the nystagmus, the thinner arrow the slow component. Peripheral jerk nystagmus increases in amplitude and frequency when looking towards the side of the fast component. Central jerk nystagmus intensity does not change with change in gaze direction, or increases when looking towards the side of the slow component. Peripheral jerk nystagmus does not usually change direction when gaze direction is shifted. Notice that despite the position of the iris, the thick arrows representing the fast component remains to the same side. Hence, peripheral jerk nystagmus is often labeled as unidirectional. Central jerk nystagmus changes direction when gaze is shifted, as you can see by the shifting direction of the thick and thin arrows. If the nystagmus is right beating when the patient looks to the right, it becomes left beating when the patient looks to the left. Hence, central nystagmus is often referred to as bidirectional. Peripheral jerk nystagmus usually changes direction with reversal of head position. This is so in patients with benign paroxysmal positional vertigo, but not so when the pathology is in the nerve. In patients with benign paroxysmal positional vertigo due to posterior semicircular canal involvement, the fast component of the nystagmus is towards the lower ear when the patient is supine with the head turned to the affected side and may reverse direction upon returning to the sagittal position. This is so because the direction of the movements of dislodged otoliths can stimulate or inhibit a canal depending how the ampulla is displaced by the endolymph. The fast component of the nystagmus is towards the contralateral side in cases of destructive peripheral lesions. Central jerk nystagmus usually does not change direction with reversal of head position. Peripheral jerk nystagmus has a latency. That is, when trigger takes a few seconds to appear, central jerk nystagmus has no significant latency. The nystagmus is present as soon as the direction of gaze shifts or very soon after. Peripheral jerk nystagmus fatigue. This is demonstrated in two ways. The nystagmus tends to last less than 1 minute and is more prominent the first time it is provoked and then fades. Central jerk nystagmus lasts over 1 minute and have similar duration regardless of how often gaze position is shifted. A good generality to remember is that peripheral jerk nystagmus is influenced by outside stimuli, but does not shift direction with gaze. Central jerk nystagmus is not influenced by stimuli, but shifts direction with shifting gaze. So the answer to this question is E. The second question is, which of the following features suggest a peripheral cause of jerk nystagmus? A. Falling to the side of the fast component of the nystagmus. B. Missing target by overshooting in the direction of the slow phase of the nystagmus. C. Abnormal cover test. D. No intensity change with darkness or lack of fixation. E. Abnormal head impulse test. This frame illustrates the peripheral and central structures involved in nystagmus. Central jerk nystagmus intensity does not change with change in gaze direction, or is most prominent when looking towards the site of the lesion. Peripheral jerk nystagmus due to vestibular ganglion pathology is most prominent when looking towards the good ear. Peripheral jerk nystagmus due to semicircular canal pathology defies localization in relation to side or vertical polarity because otolith displacement can either inhibit or excite each canal, thus producing opposite effects. In patients with vestibular pathology, the lesion is on the side of the slow phase of the nystagmus. In patients with cerebellar pathology, the lesion is on the side of the fast phase of the nystagmus. Patients with peripheral jerk nystagmus fall to the side of the slow component. This is so for patients with vestibular nerve pathology. Patients with benign paroxysmal positional vertigo do not typically fall to one side. Patients with central jerk nystagmus fall to the side of the fast component of the nystagmus. Patients with peripheral jerk nystagmus miss the target by misshooting in the direction of the fast component. Patients with central nystagmus miss the target by misshooting in the direction of the slow component. Patients with peripheral jerk nystagmus have normal cover test. Patients with central nystagmus have abnormal cover test. It may involve both eyes, in which case once either eye is on cover, drifts towards the primary position, or unilateral when only one eye drifts after being uncovered. The drift could be horizontal as represented by the arrows or vertical. Turning off the light and removing fixation accentuates peripheral jerk nystagmus. Darkness and removal of fixation has no effect on nystagmus due to central pathology. Nausea and vomiting are very prominent in peripheral nystagmus, such as in vestibular neuronitis. Except in cases of benign paroxysmal postural vertigo, these manifestations are milder or absent in central nystagmus. Peripheral nystagmus is often accompanied by tinnitus, earache, or deafness, except in the cases of benign paroxysmal positional vertigo and vestibular neuronitis. Deafness may occur in association with central nystagmus in cases of anterior-inferior cerebral artery stroke. It is important to remember that in some cases the stroke may not be evident on day 1 by MRI, but will be detected by MRI on day 3. Central nystagmus should be suspected in any patient with the 5 Ds: dysarthria, diplopia, dysphagia, dysmetria, or other forms of cerebellar dysfunction such as ataxia and dystonia. Peripheral nystagmus, when due to a canalithiasis, has very characteristic and constant behavior. In case of left posterior semicircular canal involvement, the Dix-Hallpike maneuver with the head tilted to the left will produce nystagmus with the fast component towards the left ear. The first time it will be very prominent, less on the second time, and even less on the third time. If the Dix-Hallpike maneuver is done with the head to the right, no nystagmus will be present. Nystagmus of central origin, let's say due to a left medullary lesion, may be triggered by the Dix-Hallpike maneuver with the head to the left and have a fast component towards the upper ear. It may be prominent the first trial, equally prominent the second trial, and even more prominent still in the third trial. And when done with the head to the right, the nystagmus may still be present, and in the second trial, changing direction without changing intensity. Next, we will look at the head impulse test. A video in this channel talks about it. This test is often used in the ER to help distinguish peripheral from central nystagmus. So, a central origin should be suspected if the head impulse test is normal. That is, if there is no loss of focus during turning and no corrective saccade. On the other hand, peripheral origin of the nystagmus should be suspected with an abnormal result when there is loss of focus during head motion followed by a corrective saccade. In this example, the bad vestibular apparatus is on the left side. The side of the affected vestibular apparatus is indicated by the direction of the fast twist that triggers the corrective saccade. If you find the corrective saccade during fast rotation of the head to the left, it is the left vestibular apparatus the one affected. As we have just mentioned, the rules for head impulse test interpretation are very straightforward. Positive peripheral pathology, negative central pathology. But as all rules, this rule has exceptions. Exclusive involvement of the lower branch of the vestibular nerve despite cursing with a negative head impulse test is a peripheral disorder. Wernicke's encephalopathy, despite apparently a central disease, can have bilateral positive head impulse test. And ICA infarction, despite mainly a central disease, can start as a peripheral disorder. Those start with a positive head impulse test. So the answer to this question is E. Thank you very much for your attention.